Let me hit. So welcome to our IMBCI Step 2 webinar, and we are really honored that Professor Sue Down is with us today and is going to present. And I'd like to read a bit about her bio, which is incredibly impressive. Sue has spent 15 years working as a midwife in various clinical, research, and project development roles. In January of 2001, she joined the University of Central Lancashire in England, where she is now the professor of midwifery studies. Her main research focus is the nature of and cultures around normal birth. She is the editor of Normal Birth, Evidence and Debate, and the founder and chair of the International Normal Birth Research Conference Series, which is now in its 11th year, and which has been held in the UK, Canada, China, Brazil, and this year, Australia. She was the principal investigator on the SHIP trial of the use of self-hypnosis in labor, and on the EU Coast Action on Childbirth Contexts, Cultures, and Consequences, which involved 26 countries. She's now chair of and PI for a new EU cost action, which includes 31 countries and over 120 scientists from a wide range of disciplines. The B3 survey has been a part of both cost actions. We're really proud that she's also part of our board of directors for the International MotherBaby Childbirth Organization and a member of the Global Respectful Maternity Care Council of the White Ribbon Alliance, a member of the steering group for the recent Lancet Midwifery series, and co-author on 2 papers in the series, and a member of the advisory group for the current Lancet Stillbirth series, and co-author on one of the series papers. She's a member of the technical working group on the current World Health Organization Antenatal Guidelines Development Project, with a particular emphasis on integrating qualitative metasynthesis data into guideline development, and with a simultaneous impact on the use of qualitative data with the Cochrane EPOC, and is a contributor to the current work on the new WHO interpartum and reducing cesarean section guidelines. With Dennis Walsh, Sue set up the International Journal of Childbirth, which is now the official journal of the International Confederation of Midwives. She has published over 100 peer-reviewed papers to date with Sheena, and I'm sorry if I'm saying this wrong, with Sheena Byram. She has recently published an edited book focused on care and compassion in maternity care, The Roar Behind the Silence, that is being taken up spontaneously by midwives and others in the UK and a number of other countries as the basis for seminars, teaching, and active practice change. Wow, Sue. I mean, you know, working with you, I know so many little bits of what you do, but when I sat down yesterday to read over your bio, I just was completely impressed and so honored that you're going to share your wisdom with us today. So with that, I'm going to turn it over to you to present Step 2, Midwifery Knowledge and Skills.
Thank you so much, and thank you. It was a bit of a long. Sorry, I sent a bit of a long bio there, so my apologies to everybody. But it's been great working with Imke, and I think this series is an indication of how important this work is. And you know, as those on the committee know, on the board know, it's moving forward now quite dramatically. So you know, we're all hoping, I think, aren't we, that what's being talked about in this series is going to be translated into practice even more widely than it has been in the very near future. So with that in mind, I've been asked to talk about midwifery knowledge and skills, and obviously this step, as all the steps integrates with many of the others, but it kind of is one of the underpinning ones, I suppose, because what I want to show or discuss as a consequence of this presentation is what this means, what midwifery means, and what it means for everybody, not just those who would call themselves midwives. So, if I can make it go, that would be good. There we are. So this is the phrasing around the Step 2. That's actually on the website, and I think most of you probably know about this. But I think what I want to kind of emphasise here is that there's a link between midwifery and normal physiology. Of course, midwifery isn't just about normal physiology, but there's a huge emphasis on that particular aspect within midwifery and again within the 10 steps. But I want to go back a little bit to ask the question, what do women want and need? Because ultimately this is not about a midwives professional project. Midwifery is about that which women want and need. And there was a reference to the WHO antenatal care guidelines, and I want to quickly look at what we did to set some of those guidelines, some aspects of those guidelines up. And the first thing that we were asked to do by WHO was to do a scoping review, qualitative scoping review, to find out what do women want, need and value in pregnancy. And in fact, this has kind of spilled over into birth and the postnatal period as well, because women, in fact, as we all know, don't conceptualize really labour and birth and the postnatal period in chunks. They see it as a whole episode that is a life-affirming, hopefully, or at least a kind of life-changing episode in their lives. And what we found from doing this qualitative review of all the research we could find in this area, which was not research about what women thought about services, but research about what they wanted in the absence of services, if you like, if they were to design the perfect service. And we found that whereas in the current discourse, maternity care tends to be set about in binaries, either safety or satisfaction, what we found, and this won't surprise anybody who's listening, I don't think, is that women actually want both and, not either or. Both a positive pregnancy experience and a safe experience. So across every region, culture, country, what we found is that women want, need and value the potential of a positive pregnancy, birth and postnatal experience through maintaining what they deem to be their physical and socio-cultural normality, maintaining a healthy pregnancy, which included, but was only partly of this part of this phenomena, preventing and treating risks, illness and death, effective transition to positive labour and birth, and achieving positive motherhood. And those are the things that women want and need from their experience of pregnancy, birth, and the postnatal period. And what they wanted to help them to achieve that were three key factors: support, which is a whole range of phenomena, relevant and timely information, not just a pile of leaflets, but what they needed when they needed it, and at the end, lastly, clinical care and therapeutic practices, which included therapeutic, spiritual and religious practices where appropriate. So the question is this what midwifery can do? Can midwifery deliver these things that women want and need, as opposed to just being, as I said before, a midwives professional project? And if we look back into ancient history, the notion of what a midwife is included clinical skills, observational skills, and empathic skills. So already there's this kind of link with what women were talking about: support, information, clinical or therapeutic skills. And the modern definition of the midwife, the ICM definition, continues this on. So it does talk about a midwife as a responsible professional, and we could discuss what that means, professional. It talks about working in partnership, offering, again, support, care and advice through the whole period, conducting births and providing care for the neonate. So again, these various aspects, what women want and need, what's been there in the ancient past, what we are seeing as the role of the midwife specifically now, all seem to echo this notion of midwifery. The modern definition includes preventative measures, normal birth. Again, promoting normal birth is a big phenomena a big element in what the ICM definition talks about. Detecting complications, accessing care, and carrying out emergency measures. And to support this, ICM have produced 7 essential competencies for the midwife. The first one being a knowledge base. And the reason I put this particular picture up is because I think if we look at many midwife textbooks, the knowledge that seems to be in there around physiology is certainly the knowledge in the drawings, the visual knowledge, is around women being flat on their back, which changes the physiology of normal labour and birth particularly. This picture shows what happens when a woman is doing what most women will do when left to their own devices, which is to lean forwards, and how that affects the physiology of the baby as it negotiates the birth canal. And I think that this idea about what midwives know needs to be bound up with what is also known from many other disciplines around normal physiology. Second competency is health education to all in the community, including planned pregnancies and positive parenting. Thirdly, high quality antenatal care. And again, from the ICM perspective, this is not antenatal care that's about just detecting abnormalities. It's primarily about antenatal care that maximizes health, which includes social support and isn't just about doing tests. In terms of labour and birth, from the ICM perspective, the competency includes culturally sensitive care, conducting a clean and safe birth and handling emergencies. And again, that's about maximising health rather than just minimising ill health. In terms of the postnatal care, it's a similar kind of story. Neonatal, looking after the needs of the baby or noticing the needs of the baby from birth to 2 months of age, and that includes supporting the relationship between the mother and the baby, obviously, not just weighing and measuring and looking at infant feeding. It includes support when things go wrong. So in terms of abortion-related care, either with a termination or a loss in congruence with the local laws and regulations. And all of those things come together because I think, but they also are framed in this idea of autonomy. Midwives can't accept the, if you like, the status of undertaking those 7 aspects of their work without accepting both autonomy and responsibility for doing so. And I put up the so-called 6 C's here, which is actually a nursing initiative in the UK, but I think is also really important for this notion of the midwife and separately midwifery. And I'm arguing those two things are not exactly the same, but in terms of midwifery, I think the 6 C's are highly relevant to the kinds of things that should be captured in what midwives do in the name of midwifery. And so moving on to this thing about what is a midwife and what is midwifery, I hope all of you, or most of you, have read the Lancet series on midwifery. And if you've done so, then you'll know that what we argued in that particular series is that midwifery is not just what midwives do. It's what women want and need. Again, coming back to that particular concept. Some midwives do midwifery, some don't. Some doctors do midwifery, some doulas do midwifery. Midwifery is a philosophy and a vocation. And so what is caught up in our 10 steps, I think, is this notion of this philosophy of midwifery, which also encompasses those 7 competencies potentially, but is actually far more than that. The philosophy is here. If you haven't seen this, you might not be able to see it in detail on your screens, but it's worth getting hold of it and running it off to have a look at it. The important thing about it is the design of this particular matrix is deliberately heavily focused on healthy women and babies, so that the green boxes are all about what every woman and baby needs. The pink ones at the end are what those few women and babies with complications might need. So everyone needs all 5 of those boxes, in fact. Only the women with complications need the last 2 boxes. And you'll also, I think, find, if you look in the Lancet series, that we haven't used the word, we've tried not anyway to use the word risk anywhere. We've tried to talk about complications, because risk is a notion which is very nebulous and highly elastic, whereas complications is something which is actually evident and present, and is is much less likely to cause drift between those pink boxes and the green boxes in actual practice. And I want to particularly emphasise, just because I'm going to come on to it a little bit, 2 aspects of this framework. First of all, the aspect of continuity of midwifery. And again, this is midwifery, not just midwife care. And secondly, this notion of optimising biological, psychological, social and cultural processes and strengthening women's capacities. So this is not about what a profession does to women. It's about what happens in that intersection between women and those who are practising midwifery. And I want to also just throw in this notion of salutogenesis, which again, some of you will know is a theory that I'm very fond of. And on the basis of what I've discussed before about physiological labour and birth, I would argue it is actually a core midwifery attribute. So this salutogenesis is this idea that currently healthcare in general, maternity care in particular, is framed around pathology, what might go wrong, and trying to prevent the pathology that's going to happen in the few by treating the large numbers of women and babies with prophylactic, just in case interventions. And what Erin Antonovsky, who was a social scientist who was looking at what happened in the first instance to people who have been subject to the Holocaust and expecting to find a large amount of pathology in those individuals. What surprised him is that he found that was true, but in a certain small percentage, actually there was a high level of resilience and positive outlook on life. And he built his theory around skeetogenesis on the back of these particular individuals who were able to see meaning in the world, even though they had been through the worst possible traumas that you could possibly imagine. And what Antonovsky says is, as you can see here, that actually if you start looking through the lens of what might go right, rather than always looking at what might go wrong, the lens of positive health, then you start to think in a different way about how you might be in our particular case with women and babies and families. And as Antonovsky says, we're all familiar with the concept of a risk factor. Can we not think of the concept of a salutary factor? What might make something go right? This image you can see here brings together his theory, which is that if you can maximize what is comprehensible, manageable, and meaningful about life, you create a sense of coherence, which is associated with health and well-being. And that's been shown in a large number of studies to be true. So midwifery is not just midwives, it's Midwives Plus. And this next couple of slides are taken from the book you can see here called Death in Childbirth, between 1800 and 1950. And this was also a text written by a medical sociologist. And it's an old text, as you can see, and it's looking at a historical situation, but it probably has relevance to quite a lot of countries still in the world these days. And what Luden concluded was, I found, and it was not a finding I expected, that where there was a system, and I've highlighted what I think are the important words here, a system of maternal care based on trained, licensed, regulated and respected midwives, especially in close and cordial cooperation with doctors and hospitals. The quality of maternity care was at its highest and maternal mortality at its lowest. I cannot think of an exception to this rule. And he was looking across history and around Europe looking at Europe around a time when the maternal mortality rates were similar to those in many countries that are suffering high rates in the world today. And this was his conclusion. So this notion of midwifery, as done by all, but particularly midwives, isn't just one about having a nice birth. It's actually much more profound than that in terms of its effect. And the question is, why is it particularly important these days that we put an emphasis on midwifery? Well, again, this is a relatively old text from WHO, but it's still very relevant. In fact, I think it's being updated currently, but I doubt they'll change this particular phrasing. Generally, about up to 80% of all pregnant women may be considered low risk, and that's still being said by WHO, even in countries with high rates of, for example, infectious disease and poverty. And again, I'll read this particular one because I think the emphasis is important. The uncritical adoption of a range of unhelpful, untimely, inappropriate, unnecessary interventions, poorly evaluated, is a risk. So the point being made here is that there is a risk of risk. If we set up risk systems that are out of control, we increase risk, we don't decrease it. And what's also important here is the final bit. This is done by those who try to improve the maternity services. It's not being done out on a whim or because people want to cause damage, but because people really believe it will work. And in fact, the evidence is the other way around, and we need more midwifery skills and philosophies to try and reverse that trend rapidly. And this is because we know that it's a human rights issue. So this is a ruling from CEDAW that the high rates of caesareans in Greek hospitals is actually a human rights issue. And we know it's not just in the Greek hospitals that this is going on. This is a study undertaken in the USA in 2010 when they looked at the excessive costs for unnecessary medicalization of various normal procedures, one of which was normal pregnancy and or delivery, and these figures are in millions. So you can see that the calculated cost each year for unnecessary medicalization of normal pregnancy and or delivery in the US was $18 billion. And again, it's an equity issue, and these data are from a WHO study of a range of high-burden countries. And what they found is the number of caesareans needed and not done was around 3 million at a cost of just under around about 300,000 US dollars, which is the first couple of bars you can see, whereas the number of caesareans that are overused was something like 6 million at a cost of around just something over 2 billion US dollars. And the obvious although too simplistic solution, is to stop doing one so that we can do the other and still have some money left over. The reason this is important, elective caesarean section, again, this is the same survey as in the previous slide, or linked to the same survey as in the previous slide. And in this particular survey, they found around a quarter of all births were by caesarean. And in China, 11.6% of all births were elective caesareans without medical indications. And when they looked at the non-indicated caesareans compared to the spontaneous vaginal births, what they found is severe maternal outcomes were increased for otherwise healthy women who had caesareans by a factor of something like 2.5. And then again, looking in detail at some of these data, this is a smaller subset of those data. What they found is that when they looked at women who had caesareans in the antenatal period with no indication, the odds ratio of severe morbidity and mortality for women choosing caesarean or being given caesarean versus spontaneous birth was an odds of about 2.7. Understandably, where there was an indication for the antepartum caesarean, the risk was much higher for those women because they were already sick, of 10.6 if they had a caesarean. But actually, intrapartum caesarean with no indication had a higher rate of antepartum with an indication. So caesarean for otherwise healthy women in labour has a much higher rate. The odds ratio is 14 times higher for maternal mortality and morbidity when compared to spontaneous vaginal birth, and higher even than those at risk in the antepartum period, and actually about the same as women having caesareans with an indication in the intrapartum period. So the excessive risk for women is really unacceptable. And then, of course, there's this increasing evidence, which is growing all the time, on birth interventions and later non-communicable disease in the neonate, which is possibly due to feedback loops. And there's an increase, as we know, in type 1 diabetes in the neonate, eczema, asthma, multiple sclerosis, bronchiolitis, and so on in babies born after caesarean, although we don't know whether that's actually to do with, for example, intrapartum use of antibiotics or other phenomena that surround the mode of birth. It might not just be about mode of birth, but we do know something seems to be happening. And not only is it happening in terms of illness, but it's actually happening at the level of the DNA. There are changes in white blood cell DNA methylation in cord blood in babies born after different kinds of mode of birth. We don't know which is better and which is worse. And we also know that there's an increasing evidence to support the gut flora colonization notion that's part of the microbiome hypothesis, that being born vaginally seeds the baby's gut, and that there's an interaction between the gut health and the immune system. So, childbirth based on fight-flight or childbirth based on tend befriend. And tend and befriend is the notion that is linked with midwifery, as undertaken by anybody that's doing midwifery, as I say, not just midwives. And the argument is actually that if we authentically engage with this, with midwifery and with prioritising physiological pregnancy and birth while recognising when interventions are needed and managing them, we move from just seeing birth as something to do with safety and physiology into recognising that it links to the survive, thrive, transform agenda. That actually it's not just about survival and safety. It is much more about thriving and transforming, as is evident in the top of Maslow's hierarchy here. That actually it's about self-actualization, and we should really take for granted safety needs. The rest is something that we don't ever measure. We very rarely measure as a consequence of labour and birth, but actually it matters hugely. It's what's below the waterline if we invert this pyramid in the iceberg of what labour and birth is all about, and we're missing it completely very often. Okay, so how do we know that midwifery works? Well, we do know that midwife-led continuity of care, based on a philosophy of midwifery, has some very profound effects, as in the most recent Cochrane review in this area, which basically showed a decrease in preterm birth, something which billions of dollars is being spent on in terms of drugs and pharmacies, pharmacological treatments, and so on. But we know what works, and that's continuity of midwifery-led care. So why are we spending all that money on treatment solutions? We know that continuity of midwifery-led care is linked with a decrease in fetal loss before 24 weeks gestation, and in fact, overall, a decrease in fetal loss. We know that it's actually associated with reduced use of epidurals, which is often argued to be a woman's right and what all women want and need in labour. And it's the reduced risk of episiotomy and of instrumental birth. It's also linked, obviously, with more spontaneous vaginal birth, and even though there's less use of epidurals, an increase in satisfaction in women who go through this service when they're randomised to it. it's also cheaper. So, of course, all the global agencies are recommending continuity and midwifery-led care for all healthy women and newborns, and why would they not, on the basis of that evidence? The global community supports this view. State of the World's Midwifery Report showed that even though only 4 of 73 countries have an appropriate midwifery workforce, midwives can provide 87% of what's needed, and investment in midwives can give a 16-fold return, but only, I would argue, if they're doing midwifery, not if they're there just as professionals trying to pursue a career. So the question is, if midwifery is so good, why isn't it everywhere? I want to just play this little video if I can. Then I've got a couple more slides and a final video, and then we can discuss these issues. Let's see if this works. Ooh, have we got sound? Oh, yeah.
I have a kind and caring midwife who's helping and guiding me through my pregnancy, keeping me and my baby healthy, and who'll be the comforting voice at my side when I give birth.
As a midwife, I want to have the right training and support to give women what they want, to be valued in what I do, and to be able to share my expertise when and where it's needed.
I just want a good midwife.
Around the world, 1 in 3 women give birth without expert help, while the equivalent of 2 jumbo jets full of women die in childbirth every day, leaving their families to cope with no mother. This leads to poverty, distress, and further cost in supporting those left behind. It's a downward spiral. In many countries, some women report that they are traumatized by the birth of their baby, physically, psychologically, and this impacts on the whole family. And sadly, it's not just the shortage of professionals that is preventing women getting that expert care.
I've heard that in some countries, midwives can't practice because it's illegal or because their skills aren't respected. In some places, they can't do a good job because unnecessary and expensive medical procedures are used to avoid risks that simply aren't there.
I know that sometimes midwives are working under such pressure, they forget the importance of kindness and respect. They are let down by the system, and in turn, their lack of compassion fails both the system and the woman.
In my country, midwives can be cruel. One beat my sister because she cried out in pain.
Research shows that when midwives are supported with good regulation and education, and women have sensitive, skilled, and respected midwifery care throughout their pregnancy, both mother and baby are more likely to live. But it's not just about survival. A happy and positive birth is the start of an upward spiral that strengthens the whole family to the benefit of everyone. Having access to a skilled and caring birth attendant is crucial. The evidence suggests that midwife-led care saves lives, reduces unnecessary intervention, and saves money. We must have more educated midwives who are able to be with women wherever they are needed. They should be valued and respected, and enabled to show their kindness and dedication.
I can help by sharing my positive experiences. I can talk to the policymakers to help them understand that every woman deserves the best possible journey into motherhood.
I can help by trying to change the system. I can encourage those who provide maternity services and midwifery education to understand my worth. And I can encourage my fellow midwives to practice their skills with warmth and humanity.
And you can help me. A better world starts with healthy families and strong relationships. So give me a good midwife and the birth I deserve.
Oops, let me just see if I can stop that. We've got the heartbeat back again. I'll just try and get that stopped. Okay. So what's needed to make it happen? Well, the ICM does have a midwifery services framework, which I'm not going to go into detail about now, but if anybody's interested, then you can pick up on that slide later and see what's in it, but it's at the high level, really, at a policy level. The ICM also has a core curriculum, which is 3 years long, and again, you can look at the details.
Hi guys, so as a student midwife, this is going to be a video explaining 10 different things that
we've got an
I
extra,
really
an extra
feel
thing here.
you need to know if you want to be a student midwife. Also, you know, if you want to go on to become a midwife. So,
hold on, we've got an extra person here.
This is only from my perspective. My uni, my area, my country might be different from what's going on in other unis and in other states.
Does anybody know how to turn this off?
I can only go on what I've experienced and what I know.
Hang on, here we go. Oh, that's it. Go back to this one again. So you've got an extra bit of information there. So yeah, midwifery services framework that you can use, as I say, if you want to look at a policy level, and then the core curriculum here, which again you can look at in a bit more detail maybe after this presentation if you want to, but it includes all the necessary skills and philosophies and theories that might be relevant to midwifery. So finally, just a couple of final slides. First of all, this idea that actually what midwifery is a science of hand, heart and brain. If you remember the first or the very early slides about what Aristotle said a midwife was, this goes back to that notion really. And there's a quote I've used a lot, which I'll just have a little read of while I'm talking, written by Hilary Rose, who's a feminist scientist. And basically what she's saying here is that we can frame health provision and midwifery in particular as a science, but actually if we want to frame it as something which is a benefit to women, then it has to be a link. There has to be a link between science and love. There's a danger of knowledge without love. And this notion of midwifery, in my mind, combines both knowledge and love, and obviously technical skills, techne as well. So again, the final slide, many of you will have seen this. It's another YouTube video about what we might do to be able to make change happen. It's a bit of a blurry video. It's not ideal. It was done with just found footage on a handheld camera, but I think it's quite an interesting notion tied up with it. And then when that's finished, we can go to the chat box and see what people make of all these of the presentation. So here we go.
If you've learned a lot about leadership and making a movement, then let's watch a movement happen start to finish in under 3 minutes and dissect some lessons. First, of course, a leader needs the guts to stand alone and look ridiculous. But what he's doing is so simple, it's almost instructional. This is key. You must be easy to follow. Now here comes the first follower with a crucial role. He publicly shows everyone else how to follow. Notice how the leader embraces him as an equal. So it's not about the leader anymore. It's about them, plural. Notice how he's calling to his friends to join in. So it takes guts to be a first follower. You stand out and you brave ridicule yourself. Being a first follower is an underappreciated form of leadership. The first follower transforms a lone nut into a leader. If the leader is the flint, the first follower is the spark that really makes the fire. Now here's the second follower. This is a turning point. It's proof the first has done well. Now it's not a lone nut and it's not two nuts. 3 is a crowd and a crowd is news. A movement must be public. Make sure outsiders see more than just the leader. Everyone needs to see the followers because new followers emulate followers, not the leader. Now here come 2 more people, then 3 more immediately. Now we've got momentum. This is the tipping point, and now we have a movement. As more people jump in, it's no longer risky. If they were on the fence before, there's no reason not to join in now. They won't stand out, they won't be ridiculed, and they will be part of the in crowd if they hurry. And over the next minute, you'll see the rest who prefer to stay part of the crowd, because eventually they'd be ridiculed for not joining. And ladies and gentlemen, that is how a movement is made. So let's recap what we've learned. If you are a version of the shirtless dancing guy, all alone, remember the importance of nurturing your first few followers as equals, making everything clearly about the movement, not you. Be public, be easy to follow. But the biggest lesson here, did you catch it? Leadership is over-glorified. Yes, it started with the shirtless guy, and he'll get all the credit, but you saw what really happened. It was the first follower that transformed a lone nut into a leader. There's no movement without the first follower. See, we're told that we all need to be leaders, but that would be really ineffective. The best way to make a movement, if you really care, is to courageously follow and show others how to follow. When you find a lone nut doing something great, have the guts to be the first person to stand up and join in.
So there we are. That's the end of the presentation. Any comments and chats in the chat box, I think.
Thank you so much, Sue. That was really fantastic. I think some people were writing in that video wasn't moving well, but there you go. You're putting up what it was. So those of us that don't know it can see it later.
Yeah, okay. It's a shame because the people didn't see it, but yeah, you can definitely look at it later on.
So as Sue said, please write your comments in the chat box so we can continue having a discussion. You brought up so many fantastic points and great resources. So thank you so much.
Thank you. Thanks for the opportunity. Let's see what people have got to say, if anything. Do you mean the video, Ray?
Actually, I mean the whole thing, Sue. It was
okay.
Yeah, so much information, and I think if anything, right now we could somewhat share some of our favorite parts of this whole thing. And my favorite part was you reframing the word risk and practicing, or not using risk as part of your practice. And I just thought that was such a valuable piece of information and a real good, such a wonderful way to look at caring for women. So thank you for that.
Well, that was really the whole of the Lancet Midwifery Series group. It's not just credit to me. It's certainly, mostly it's Mary Renfrew and Petra Tanhoop-Bender who led the Lancet Midwifery Series. And I think that was, it was a conscious effort. And it's very hard to do. And I still catch myself sometimes saying risk and thinking, no, stop it, because it's so endemic in all that we do, and it's so corrupting and corrosive, and it's quite liberating when you get away from it, if it's possible to do. Yeah, Mary. I mean, that was kind of part of the point of the final video. Really, it is frustrating that midwifery is the solution. I mean, it's a bit like group women's care. The Lancet series on women's groups in various countries that show such fantastic results, and yet people are still critiquing those results. And you think, goodness, if that was a drug or a technique, it would be mandated for everybody. It's a peculiar fact that personal, interpersonal relationships are just not seen as being powerful when we all know they really are.
Yeah, this is Mary Sue. Thank you. I was just going to say also I've just gotten really interested in implementation and dissemination science, because I think it's like the big question always is, we know what to do, how come it's not happening? And you can fill in the blank about whatever aspect of care you're talking about. But it just blows my mind that, because I always think a lot of the world revolves on economy and on money, and the work you've done and other people have done have shown what a difference this can make, to the economies of countries and in savings, et cetera. And it's just so interesting that it's not, people breaking down our doors for midwives.
Yeah, absolutely. I mean, I think it's because people just don't believe it, to be honest. They just can't believe it can be possible. I remember, and this is a slightly different topic, but it's along the same lines. They were reorganising maternity services in one of our local, in Manchester, in the Manchester area near to us, a few years ago now. And the discussion was whether to have alongside units or midwife-led unit, freestanding units as an alternative to a hospital. So, I mean, I was asked to do a presentation, which I did, on the evidence on both alongside and freestanding, which basically shows that freestanding are better. You know, that the outcomes are better for freestanding units, and better in freestanding units than in hospital, and for low risk women. For healthy women. See, I've done it myself there. For healthy women, not for low risk women. And at the end of the whole presentation, they started debating what they were going to do. And they said, yes, so of course we can probably have alongside units. And I said, well, why would you have alongside units when freestanding units are actually safer? And they said, oh, well, no, they're not, because they're further away from the hospital. And I said, well, I've just presented a whole load of evidence to show you they are. And they said, well, they can't possibly be, because they're further away from the hospital. So it's a huge leap of faith we have to make, I think. And I mean, I do believe in tipping points, and I think, again, that's why this video at the end is important. I think what complexity theory argues is that you would argue is that you have to keep working to create the initial conditions at which point a tipping point can happen. And that those initial conditions might take a year, they might take 25 years, but you just have to keep working away at them. And then at a certain point, suddenly you'll find that people are switched completely, and you won't quite know how or why it happened, but it'll be a consequence of all that kind of, hard work that seems to be completely unrewarded for years and years before that. And we just have to have faith. We have to have faith, I suppose, that if for both healthy women and women with complications, that we'll get to that point sooner rather than later.
That's really a wonderful perspective. I just, and then I'll be quiet because I know other people are saying things, but it also reminds me of the Thomas Kuhn, scientific revolution. I can't even talk, but one of the things they talk about in there is that before the change, before the transformation, people who are talking about what's coming sound insane to everybody else. I mean, it's so outside the worldview of everybody else that they think you're nuts. And I think your point about people just don't believe it because it doesn't fit their worldview, I think that's right on.
Yeah.
Thank you.
And in fact, Einstein, there's a lovely quote from Einstein, isn't there, which is, insanity is doing the same thing over and over again and expecting a different result. So the question is, who's insane? Who's insane in this dynamic?
Good.
So, Ray, could you address what's happening with the loss of support for TBAs? I guess you mean in the global community, Ray? I haven't quite caught up with this. To me, this seems to ebb and flow, this whole TBA debate. I know there's been a debate on the HIFA list about it, which actually is highly supportive of, it depends whether you call people skilled birth attendants or TBAs or community workers or lady health visitors or whatever you call them. But my sense was that there's an increasing support again. There was a piece of research that didn't show huge benefits, but it looked like they were addressing the wrong question. That was a few years ago. I don't know if anybody else on the call knows more about this than I do. You could type in the chat box if you're not going to talk.
Well, that was what I was asking, was about that research that you were talking about, and of course the centralization of care, how they want all women to come into these facilities and not get good care.
Yeah.
So, yeah.
Yeah, I think the disrespect and abuse agenda is beginning to turn that around a bit because it's institutionalized care that it kind of engenders this disrespect and abuse phenomena, isn't it? Mm-hmm. So my sense at the moment, certainly at the WHO level, is that's in a state of flux. Some of that debate is in a state of flux. It'll be interesting to see what comes out of the intrapartum care guidelines that are being managed a bit differently from the antepartum ones, although we've still been asked to do this work about what women want and need as a primary focus for what should be delivered, what care should be delivered. So how that plays into the final guidelines, we shall see. But I suspect, we're going to find the same thing as we did for the pregnancy ones. Women want social support, they want care to be tailored to their cultural needs, they want to maximise the chance of positive birth, they want a healthy baby as far as possible, etc., etc. So I don't think we're going to find much different from that, and nor would I expect that we would. And ultimately, I suppose you could say in an ideal world, we would want every woman to have access to kind, compassionate, caring, trained, educated midwife with the support of doulas, etc. But in countries where that's so far away from being possible, TBAs are the obvious solution, especially as women like TBAs and prefer to go to TBAs very often. So, I'm rambling a bit, but my sense. There was very interesting, actually, there was a very interesting set of discussions on the HIFO list that some of you may have seen, which was about what motivates voluntary community health worker, TBA type people, not just in maternity, but across the board. And there was lots of eloquent chat on there about altruism and love for the women and engagement with the process, and some beautiful sentiment on there, which was truly vocational. And I think it was quite eye-opening for many professionals who were reading that list. So I think there is a change in the general atmosphere in this direction. At least I hope that's what's happening.
Is there any global effort to give doula training to TBAs? Does anyone know of any?
I don't know. Anybody else?
This is Mary. I've done some work in Haiti, and have also, visited and talked with a Midwives for Haiti project. But this is kind of, I think, close to what you're saying. But it's something like, I can't remember but it's like 92% of the births in Haiti occur at home, and it's primarily with the TBAs there, which are the madrones, and matrones. I can't say it right, it's French. But anyway, they what the government, what they were telling me is that the government used to have a program trying to support the education and supplying of equipment to the TBAs, and then they abandoned it. And so the Midwives for Haiti have, not only do they train people to be midwives, but they do a special training for the TBAs, and have created a system where once they kind of go through their courses, they keep they're getting the matrons to keep a visual, it's a record of what happened at the birth, but it's all pictures. So they just circle, like there's a circle for hemorrhage and there's a circle for, different outcomes. And then they turn in these cartoon pages and they are given supplies to help with the birth, et cetera. So I think that's one example of trying to enhance the TBA skills without saying everybody has to go to school and become a midwife.
So Celine's asked this question about how to value continuity of care. And I've just written down that I'm pretty, well, certainly in the draft of the WHO ANC guidelines I saw, there was a recommendation that where there were sufficient, where there's a body of trained midwives, trained and educated midwives, and an effective health system, that continuity of midwifery care should be recommended. Continuity of midwife-led care, midwife-led as opposed to midwifery in this case, but still, should be recommended on the basis of the evidence. So whether that makes a difference, I don't know. But maybe again, in line with this first follower video, once those guidelines come out, we should be strongly promoting that with our health systems, particularly at the levels that we're able to influence. If that's what the evidence says, and that's what WHO are recommending. I'm just trying to see what's higher up on the chat list. I'm not sure if I can go up the chat list.
Yes, you can. You should be able to scroll up.
Oh yeah. I got it. Genesis, cultural shift. So Julie Mould, is that how you say it? We need a cultural shift where women are educated about pregnancy and all other womanly issues from an early age, so they can own their experiences. Do you want to say something about that? Julie Mould. Do you have sound? Can you put something in the chat box? One new message coming in. Too noisy around here. Okay.
Okay.
So let's have should we talk about that one? So educating women from an early age. I mean, actually, this is a really interesting one. I've just, I don't know if anybody follows the conversation, which is a kind of like a Huffington Post thing that you get online. There was a recent piece on there which basically was saying we should be obligated to tell women not only about the risks of cesarean but also the risks of vaginal birth, because women should be able to choose equally between the two, because most women who try for a vaginal birth end up with all kinds of interventions and forceps and goodness knows what, and that causes problems for them in later life. And the piece was interesting because it was framed around women's choice without I think unpicking the fact that if we don't critique the current system and we suppose that the choice is only really technocratic birth or cesarean, we end up a bit like Henry Ford, who said you can have any colour as long as it's black. And if we don't start providing alternative colours like physiological birth, midwife-supported birth, midwifery care, then women are going to choose cesarean, because why would they choose a technocratic birth with drips and drains and being flat on the back and in pain and episiotomy and lithotomy and forceps? Why would they choose that? So I think it's an interesting debate about how we shift the notions in women's heads that that's what birth is.
But that article was a particular misinterpretation of the legal ruling Montgomery versus Lanarkshire, in that it didn't drill down into the essence of the law, which is about promoting patient autonomy and respect for bodily integrity. And that was what the ruling was around. It was not about normal birth versus cesarean. They have just manipulated the scenario for another agenda.
I agree, Amali, but I think the problem was and is, and there was a New Scientist article that was similar, actually, that came out, a second one that came out just before, is that people are beginning to talk about vaginal birth without recognising that it encompasses all these phenomena, all these interventions, and wrapping up physiological birth in that notion of vaginal birth. So vaginal birth slides into normal birth, which slides into physiological birth. Women are increasingly seeing that whole range of possibilities as just this far extreme, well, not the far extreme, actually, the current commonly practiced kind of birth. And because the evidence, when we look at the evidence base, it tends to talk about vaginal birth versus cesarean without unpacking these various different kinds of vaginal birth that actually are very, very different in philosophical orientation and in outcome. And I think that's, for me, that's a real concern. And it comes back to this issue about how women are brought to understand what birth is and what it can be. Again, that's a bit of a complicated way of framing it. I don't know if anybody understands what I'm talking about.
Mary, it makes a lot of sense to me. It's kind of interesting too that we've unpacked cesarean somewhat, into our various. Now we're actually tracking primary versus secondary and repeat and success rates and attempt rates and all that. But that's really good. We have not unpacked, vaginal birth.
No, absolutely. And I think that there's a study that's being kind of bounced around at the moment, which is by an Australian obstetrician around, you may know this one, Amali, around imaging of, it's to do with pelvic floor avulsion, and they've done imaging of the pelvic floor in women and shown that there is a degree of detachment of some of the ligaments after inverted commas vaginal birth. And they have, first of all, they haven't shown this is actually linked with incontinence, and secondly, they found, unsurprisingly, that it's most common in women who have forceps and episiotomy. But the way it's been reported in the abstract and then subsequently is this is about vaginal birth. This study shows that vaginal birth leads to increased levels of incontinence. So women are reading that as, well, if I don't have a cesarean, then I'm going to have all this damage and I'm going to be incontinent. As opposed to, well, if I have a birth which involves lying on my back, having a drip, having a forceps, etc., 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 then I might have a risk of incontinence, but I don't yet know because they haven't actually looked at the actual outcomes for these women. So it's this way, the question is how to get into the media, I suppose, so that some of these stories are framed in a way which is much more likely to give women proper grounds for consideration rather than notions that are simplistic and, in the end, unhelpful.
But most of the learning in the RCOG about incontinence say that only the first cesarean is possibly protective. With genuine stress incontinence. Any other cesarean section does not protect. So there is an alternate, sort of another angle at looking at the issue.
Yeah. Yes. So I guess that's the question, isn't it? If we know that this evidence, on the one hand, if we know that in a system which prioritizes midwifery, in the broader sense of the word, women are much more likely to have much more positive outcomes. And the trick is how we build that knowledge into a system which supervalues the opposite. And I mean, we know it can be done because we know it's done in some hospitals, we know it's done in midwife-led units. And it does seem to me, going back to the salutogenic question, that actually that is the solution, to say, okay, rather than always looking at what goes wrong, let's look at all the places where we know it's successful and find out what it is that they do that means they can operationalize this in hostile environments. So you can have a hospital, I mean, the Royal College of Obstetrics and Gynecology in the UK have done this work. You can have a hospital within miles of another one where the interventions are much lower and the outcomes are much better for the same kind of women in the same financial system with the same kind of social pressures. How is it that they do that? I think it must be the primary question.
I do think that it's well overdue that the RCOG have a normal birth module, which encompasses all of what you've said, and even movies of out of hospital birth, such as Deborah's own movie, her orgasmic organic birth, of rare footage, so that obstetricians are informed. There's a gap in education that needs to be bridged.
But is this, I mean, obviously that's beyond the UK as well, isn't it, Amali? So, we would be saying the same kind of thing in other jurisdictions. But then I suppose, I mean, I agree with you, but I also think that this is actually as much about the media and as much about lawyers and as much about politicians, because it's about a social framing, isn't it? Which is kind of almost, it may have been engendered by the way obstetrics has been dominant over the years, but now I think it's actually run away from obstetricians. I think you know more about this than I do, but I think there are a number of obstetricians who think, oh my goodness, this is out of control now, and it's kind of run into the media. There was an interesting piece in the Guardian by a feminist writer, a newspaper, a heavyweight newspaper in the UK, and the headline was something like, well, basically it was in favour of elective cesarean section on demand, and it was saying, the headline was, if you want an experience, go to Disneyland. So it was framing birth as a procedure to be got over with as quickly as possible, with absolutely no recognition of the life-affirming potential for labour and birth. And this is something which has been taken up, as I say, by a feminist journalist who's usually very insightful. And I think that the notion of what labour and birth could be has run away into society in a way which is now very difficult to rein back unless we get hold of the media representations.
I have to say that media representation is a big issue with all news at the present age, and it's very difficult to get the true story. So the media issue is rather bigger than birth.
Absolutely. Absolutely, yeah. So the question is, given that, and given that people are getting messages across, how do we deal with that? And Celine asked the question, who's gaining from this framing? That's a very interesting question. What do you think, Celine? I mean, in countries where health is privatized, I think that's an easier question to answer. I mean, it is undoubtedly true that in jurisdictions like the USA, where health has become an industry, there are clearly commercial gains to be had, and that's actually a much more difficult nut to crack. But in jurisdictions where that's not the case, and where the funding is coming from the government, and one does wonder, really. We're actually 2 minutes after the finishing time here. Yes. And I don't know. I mean, I think I'm supposed to give you some hints and tips that make you go away being positive rather than negative. So I think I would actually say that I think, for me, the movements that are happening in WHO are really encouraging, and the kinds of debates that are happening on HIFA are really encouraging. So the hints and tips really are that we should just keep on being the first followers, as in the final video, if you get to watch it. Keep on creating the space in which we can frame, I mean, if as a minimum, talk about labour and birth in terms of healthy women and babies and those with complications. Maybe that's the first thing. To try in all of our conversations to use those terms, to try and move away from the risk agenda in our own lives. That's the first thing. Second thing is, I suppose, if any of us are doing research, to try and frame the research around these positive notions of what works, where and how. And I suppose the third thing is just to keep the faith, because I think the more we do this, the more researchers do it, the more we talk about it, the more likely it is that this midwifery philosophy is going to surface, particularly on the back of the Lancet series. So keep doing what you're doing, I would say, and celebrate yourselves for doing so.
Thank you so much, Sue. This was really a wonderful discussion. We could go on, I think, for hours on so many of these points. And we can carry this discussion on over on our Facebook group in the coming days. This video will be posted both on our website and Facebook. So I hope that the discussions continue.
Thank you to all.
You're getting lots of thank yous there. And to everyone that's with us, we hope that you're signed up with us at imbci.org to be on our email list so that you'll get notification of each of our monthly STEP webinars. So if you're not, please jump over to imbci.org and sign up. And we look forward to seeing you online on Facebook or Twitter and continuing the conversation there, or to seeing you next month. And we'll keep the box open for another couple minutes if you have any closing comments that you want to send. And then we're going to be moving on for a board call.